Welcome everyone to the webinar on leveraging data to address sickle cell disease. My name is Maya Lang and I lead the Business and Digital Service team at the Office of the Chief Technology Officer at the Department of Health and Human Service. I'm excited to have all of you here today tuning into this webinar, which has been months in the planning and features national leaders in the fight against sickle cell. Hardworking clinicians, policymakers, providers, and government personnel often work in silos, engaging patients and families separately and neglecting their cross-disciplinary perspectives in a collective effort to improve outcomes for patients and families. Health Plus is a program that utilizes human-centered design research to better understand the high-impact health issues in focus. Health Plus constructs a more supportive infrastructure around the most medically vulnerable populations in the U.S. through public-private partnership, cross-industry dialogue and collaboration, and creative problem solving with the potential for policy, code, and system solutions. I am one of 100,000 Americans living with sickle cell disease, the most common inherited blood disorder in the United States. As a lifelong condition, it can cause both acute and chronic pain. Sickle cell disease patients regularly describe frequent visits to the emergency room and the ongoing challenges of identifying physicians and specialists who are familiar with the condition. To start the webinar, Joel Gurin, the president of the Center for Open Data Enterprise, often known as CODE, will be describing some of the background research his team has conducted and how sickle cell data may be applied to improve health-related outcomes for sickle cell disease patients. Next, we are very fortunate and excited to hear remarks by the Assistant Secretary of Health, Admiral Brett Giroir, who will talk more about HHS's efforts to improve the livelihoods of people who live with sickle cell disease and accelerate the identification and implementation of innovative solutions to increase the quality of life for patients with sickle cell. You will also get to hear from the president of Howard University, Dr. Wayne Frederick, who will discuss how Howard University is increasing its own data collection efforts to address the lives of patients with sickle cell disease. Lastly, you have the opportunity to hear from Ankit Sutaria from the Georgia Department of Public Health, who will describe state-level efforts to increase data collection. Just a few housekeeping items before we get started. This webinar is being recorded, and we'll post the live stream on YouTube later this afternoon. For anyone who cannot hear, we'll have the chance to view it. We'll send out a link to the webinar later this evening. If you're planning on tweeting about this event, please use the hashtag SCD Data 2020. Finally, there'll be a 5-minute question and answer period with the Assistant Secretary for Health after his speech. We'll take additional questions and at the very end of the webinar. As a final note, for the people who will be participating tomorrow's roundtable, please note that if you're attending the breakout sessions, tomorrow we'll have a half-hour session following shortly after this event ends at 1 p.m. to do a deeper dive into the logistics for attending those breakout sessions tomorrow. Now, here to tell you about the research that has gone into this work, Joel Gurin, president of the Center for the Center of Open Data Enterprise and our co-host of the event.
Great. Maya, thank you very much. So my name is Joel Gurin, and I'm the president of the Center for Open Data Enterprise, or CODE, a nonprofit organization here in Washington. We're very excited to be partnering with the HHS Office of the CTO to bring this webinar to you today, and very heartened to see so many people joining us on this webinar. Next slide, please. So CODE's mission is to help maximize the value of open government data for the public good. We bring data leaders in government together with their stakeholders in academia, the nonprofit sector, and the private sector to find new ways to share data and put it to use. Over the last 2 years, CODE's worked closely with the HHS Office of the Chief Technology Officer to co-host roundtables on using data to address the opioid epidemic and Lyme disease, as well as a series of roundtables in 2019 that focused on improving health data sharing in many different ways. So we're honored to further this partnership with HHS to bring all of you together today for this webinar and to co-host the smaller roundtable that some of you will be joining tomorrow. Next slide, please. As part of our work, Code has put together a briefing paper on leveraging data for sickle cell disease that we hope you will all have a chance to read. You can access the paper by visiting dataforscd.crowdicity.com, the URL at the bottom of your screen, and clicking on briefing paper on the home page. The paper provides a lot of context about the state of sickle cell disease and its treatment, and then describes how new kinds of data collection, data sharing, and analysis could lead to great improvements in how we can all help people who live with this disease. So the Code team covered a number of areas in our paper. We wrote about model data collection efforts around the country, like the pilot data collection programs in California and Georgia, and what's needed to build on those examples nationwide. We also explored data on the social determinants of health, factors like socioeconomic status and access to medical care, which are critical to understanding disparities in care around the United States and how they apply to sickle cell disease. We've written about how these different kinds of data can be applied to three major priorities that HHS has identified for improving care for sickle cell disease, which are also going to be the areas we'll focus on at tomorrow's roundtable. I'm just going to touch on those very briefly. Next slide, please. So the first is improving continuity of care for patients with sickle cell disease, which is really important in the patient's journey from pediatric to adult care. There are a number of interventions using available data that could really improve this experience, beginning with genetic screening at birth and continuing throughout life. You'll hear more about this approach as a little bit later in this webinar. Many kinds of data, from electronic health records to analyses from the Centers for Medicare and Medicaid Services, may be valuable here as we review in our paper. Next slide, please. The second major area of focus is improving sickle cell disease care in the emergency department. Many people who suffer from sickle cell disease have to make frequent trips to the emergency department for help with acute pain, but they may not receive good care there. Our research showed that many emergency department physicians may not have the proper knowledge or experience to work with SCD patients. But again, we think there are several types of data that could improve emergency care, including mapping disparities in medical care, drawing on electronic health records, and using hospital admission records as well. Next slide, please. The final priority area is assessing treatment options and improving sustainable treatments for sickle cell disease patients. Now, there are clinical guidelines for the treatment of sickle cell disease, but they're not fully consistent and they're not universally known, and care may also be unaffordable for many people with this disease. So many SCD patients choose to utilize the emergency department rather than a primary care provider, but we think that both through changes in the type of care received and evaluating the kinds of treatments available, there's a great opportunity to improve care for people with sickle cell disease. So these three areas are really the focus of the briefing paper and what we're hoping to focus on in tomorrow's roundtable and in work going forward after tomorrow. Next slide. So this is the Data for SCD platform that we've set up, powered by Crowdicity, and that HHS has now established. We hope you'll all have a chance to explore the Data for SCD site, read the briefing paper, and share your comments and thoughts. And we look forward to discussing these issues and opportunities with those of you who will be joining tomorrow's roundtable, and with all of you as you contribute and share your ideas and suggestions for addressing this very important public health problem through the Data for SCD platform. So thank you all. And now I'm going to turn it back to Maya to introduce our speakers for today.
Thanks, Joel. I'm now very happy and excited to introduce our keynote speaker to this webinar, Admiral Brett Giroir. He is the Assistant Secretary for Health at the Department of Health and Human Service. He leads development of HHS-wide public health policy recommendations and oversees 11 core public health offices, including the Office of the Surgeon General and the U.S. Public Health Service Commission Corp. He also serves as senior advisor to the Secretary for Opioid Policy and has helped spearhead some of the department's more innovative work. Among those efforts, the Assistant Secretary for Health has long taken an interest in sickle cell disease and using data to address its consequences in a public health setting. Admiral, I'm going to turn it over to you now. Thanks.
Roundtable on leveraging data to address sickle cell disease. And Maya, you've really been awesome. I mean, you are so passionate, but so organized and meticulous. I know when I get an email from you, everything is outlined in detail, and I know exactly what went on. So I really do appreciate that. There are probably new people who are in the webinar today, and I don't know how many hundreds or thousands or who is here, but I do have a passion for sickle cell disease. I'm a pediatric ICU doctor and ran a children's health system in Dallas, and it was always a disease that I saw as just an awful one with children. When I was first practicing, there was no neonatal screening. So we'd get an infant in with a splenic sequestration or with pneumococcal sepsis, and that's how sickle cell was diagnosed. So I really am back into the Stone Ages, but have seen everything progress. And of course, I think all of you know that one of my wife's and I's mentees, who's probably on the phone, sham on you, Shamanica Wiggins, who's now a tremendous advocate, was like a third daughter to us. So got to take care of her sometimes in the hospital, but also really and continue to experience sickle cell through her life and her legacy that she's bringing. So I am very passionate about this. There's nothing I would rather be doing. And I do want to open just with a sad note, but to acknowledge that another warrior was lost this week, Marcus Valentine, brother of Ashley, co-founder of Sick Cells. And I know our hearts go out to Ashley and their family and to all his friends and all the people he touched. So for the last few months, I've mostly been involved in COVID. If you watched any of the press conferences, I was usually dressed in blue. But as of last week, I'm able to maintain or restart again a lot of my duties as the Assistant Secretary for Health. Although I was totally focused on coronavirus, as many of us were, I think we've learned a lot about the healthcare system and things that we can do differently in coronavirus that we can apply to many aspects of the system, like how do we use more of our workforce, like pharmacists, to extend care? How do we do telemedicine so that people who can't get to a physician or can't get to an office can really get care for themselves? I've also been in very close contact with the other ASH, the American Society of Hematology, because they're working on a COVID registry related to sickle cell disease. And we don't know the answers to this now, but it certainly does appear that people living with sickle cell disease are at particular risk from COVID, that the mortality rate, the death rate is pretty high, and it's not generally due to the lung disease, but certain sudden death syndrome. So I want to make sure that everybody in the line who loves someone with sickle cell disease or is a person with sickle cell disease uses precautions. But it also tells me that we need to make sure that when there is a vaccine for COVID, for the coronavirus, that we need to make sure that people with sickle cell disease are among the first in line because they are very high risk from the sickness. I think we've also learned, before I get into sickle cell a little bit more, that we've learned that our what we call resiliency of our healthcare system is pretty poor, pretty inflexible. While we needed to divert so many resources to COVID, childhood vaccinations have plummeted. Screening for breast and colon cancer has plummeted. And in the case of non-emergent treatment for sickle cell, including gene therapies, those were halted during the period. So that was really impeding progress. And I'm sure many people with sickle cell might have suffered at home in pain because they didn't want to go to emergency room to risk themselves getting infected. So another lesson that I have is really understanding that while we're battling COVID, we can't forget everybody else who doesn't have COVID and make systems that can really work for everyone. That's one reason why I think today's discussion is very important. The focus of CTO mapping out the care journey of people with sickle cell, leveraging data to address the challenges, particularly when transitioning from a pediatric to adult care, is really so important. And you know, I've seen this working in a pediatric hospital that not always, but most often the care that children receive with sickle cell is really quite exceptional because children's hospitals have the resources and they're focused, 1 or 2 children's hospitals in major areas. But when children graduate to go to college, the world changes very abruptly, and all of a sudden that care is not there, the transition is not there, and often that's when people get into trouble, right when they're ready to go out on their own and form those educational experiences that they need. So 2.5 years ago when I came in, my first initiative was to work on sickle cell disease. And I'm going to officially change our goal. What I said there, and I've challenged everyone within HHS and in the White House, is to increase the lives of people living with sickle cell disease by at least 10 years, within 10 years. I'm officially changing that today to not increase by 10 years, but to normalize the lives of Americans living with sickle cell within 10 years, and that's now within 8 years. That means a normal lifespan. That means a life that is totally or almost totally free of pain and suffering and full of opportunity. And I'm going to say that and challenge that because I think we've made so many steps in that direction that we're really right on the cusp of that. And I want to be in the generation that puts sickle cell in our rearview mirror, certainly in this country and throughout. So in 2018, we organized and convened the HHS Sickle Cell Disease Work Group. We brought 60 members from 11 agencies to align efforts and to prioritize sickle cell activities. And we've made just, I think, tremendous progress during that period of time, both substantive progress as well as important public awareness progress. Since the first time since 1983, the president has done 2 messages on sickle cell disease, trying to raise awareness and understanding across. We made sure that when we did our pain management task force in that report, there was a special section on treating pain with people with sickle cell disease and how, unlike other people, they may require very high doses of opioids and they deserve to be treated. And we outlined the discrimination that is often faced by people going to the emergency room. That subsequently turned into a CMS notice that basically said, don't count sickle cell patients in your opioid edits, that they can get they get a different pathway because they're a different group of people. That may be a small thing, but I know these are things that we've accomplished that hopefully will bring pain relief to individuals. Dr. Felicia Collins, Rear Admiral Felicia Collins, started out as Captain Collins, now she's Admiral Collins, is our leader in the Office of Minority Health. She and Captain Wong, David Wong, started the STAMP program, and this really is to help address the gap in knowledge of physicians and other care providers for treating people with sickle cell disease. There's a shortage of hematologists. There's a shortage of sickle cell trained hematologists. So this is really to address that gap. HRSA collaborated with our OMH to deliver new telehealth series for primary care providers called STAMP, the Sickle Cell Disease Training and Mentoring Program. This free series covers the basics of sickle cell disease care, such as pain management, hydroxyurea, and preventative services. And although I can't talk about some things that OMH has coming up, there are some really exciting programs that are upcoming, including some models and some funding to help state Medicaid programs improve the compliance with hydroxyurea guidelines. It's an old medication. It's a really good medication, but still we see less than a quarter of people who could benefit from it are given the opportunity to have it. There's also just a plethora of new investigational drugs under review by the Food and Drug Administration. And in November 2019, while I was actually the acting FDA commissioner, we approved 2 new highly effective drugs for sickle cell disease, which we're now seeing implemented within the community. I will also say that although I'm excited about that, I was just alerted in the last day or 2 that there's some prescribing restrictions that are being put upon sickle cell patients by Medicaid programs. And we're going to investigate that very hard because to my knowledge, there's no medical reason why they should be there. I'm not making that conclusion right now, but as I see it, these are different drugs with different mechanisms of action, and the label does not mean that they need to be prescribed sequentially only after you fail one, go on the other. So my team is going to be looking at that hard in the next couple of weeks to see if that's medically justified. And if not, we're going to go to war. We're also seeing more than ever with NIH, the Cure Sickle Cell Initiative. And again, sickle cell can be cured now, but it's not widely generally available. It requires transplantation and lots of medications. But I think we're going to transcend that just within a few years to see therapies that need less myeloablation or bone marrow toxicity in order to get fixed. So we're very excited about that. And Francis Collins, who's the director of the NIH and an incredible scientist, you know, he confided in me that in his graduate school time, his goal for his life was to cure sickle cell disease, and he still says that is his goal. So you've got the head of the NIH and you've got the Assistant Secretary for Health. This is our true goals to make this happen. I did want to mention this the last couple minutes that our drive for progress in sickle cell disease is not just domestic, but it's worldwide. I was just confirmed as the U.S. representative to the executive board of the World Health Organization, but have been working with the WHO for the past 2 years, primarily about the plight of people with sickle cell in sub-Saharan Africa. There are 300,000 to 400,000 babies each year that are born with sickle cell, and it's estimated that 80% of them die before their 5th birthday. And that's just unacceptable. And we know we can do better just by implementing simple newborn screening, penicillin prophylaxis, and basic vaccinations. The academic community suggests that we can save 9 million children by the year 2050, 80% of them in sub-Saharan Africa. So at the World Health Assembly, I brought together leaders from all the African nations, health leaders from around the globe, and the World Health Organization to have our first meeting for a sickle cell coalition. And this February, I co-hosted with the World Bank the first convening of the Global Coalition on Sickle Cell Disease, which brought together public and private stakeholders. And I'm not going to sugarcoat this. The COVID pandemic has really sort of put the brakes on that for a few months. We are really working, and Rachel Kellogg here with me is working specifically on that, Juliana Richardson from Global Affairs, to sort of rekindle that because we really want to get the momentum back up with that. So with that, I just want to say that I'm thrilled for this seminar. I am really committed to this cause. I really am committed to this cause. I want to work with you. I want to work for you. And I am continually inspired by you. And I want you to know that our staff is available, and if there's an opportunity for us to help in any way, we can. But stay tuned. There are a lot of good things coming in the next few months that I'll be excited to share with you when I can. And I'd be happy to take any questions that you have for the next few minutes. I don't know how questions work, but Maya, it's all yours.
I know. Thanks, Admiral Giroir. We are taking questions in the chat. I think we have enough time for about 1 or 2 questions. So I'm just waiting to see if anything comes in. We do have a request to share the CMS notice for opioid use with sickle cell disease. So we will work to get that dropped into the chat. I think in the meantime, Admiral Giroir, I think if there's an opportunity, we have about 5 minutes just in the presence of, here goes the question. So does COVID affect those, how does COVID affect those who are carriers? Do you have a sense of that? That's a question.
That is a super great question. I'm going to tell you, we have no idea that answer yet. We are working with that. Sorry. We are working with that. And again, the American Society of Hematology has a registry that they're trying to collect the effects of COVID on patients with blood cancers and blood disorders like sickle cell. To my knowledge, that is the best place for that data. So I would encourage all of you that if you are a carrier and you have been affected by COVID, whether you're not very affected or not, if you've had it, if you've been diagnosed, to work with ASH and work with your hematologist to work with ASH to get that data there. We just don't know that. We just don't know that answer.
Great. I think we have time for another question. What actions might the public take to support these efforts? It's a good one.
So, number one, I think I'm always for tangible. I'm always for tangible actions, but number one, I think, is we all do need to raise awareness of this. I think it really is important to raise awareness. The second thing, and I can't tell you to do this because I'm a government person, and I can't tell you what to do with your elected officials, but you need to hit your elected officials, right? There's nothing more powerful than when your congressperson is back in his or her district. Make an appointment. Talk to that person about the needs of patients with sickle cell and their families. And that just doesn't mean medication needs, but that means, you know, it's hard to finish college in 4 years if you have pain crisis and other things. We need some extra time. We need some extra support. It may take 6 or 7 years, but you're going to get a lot more out of a patient who's had this life experience than you do from other people who finish in 4 years. So I would say talk to your representative. And the rubber meets the roads at your congressman's office and your senators. You don't have to meet the senator always. They have these staffers, like their legislative directors, that really work. And so I think that's really important to really get this, because we're going to be pushing a lot of things, and we have a lot of plans that would require some significant funding that are going to blow the doors off of how we take care of sickle cell. These are things that are internal now, but once they get to the Congress side, we want to make sure that everybody understands that they need to support and fund them. Because like the sickle cell legislation a couple years ago, that was a great triumph in that it raised awareness. It had a lot of people there, but guess how many dollars was associated with that? Zero. So it's nice to have the piece of legislation, but you know, if there's no money, there's no mission. So we want money to support everything that you guys are doing on the private sector as well as the government programs.
Going to do one more, and then we're going to have to move on. So thanks for this, Admiral Giroir. This question comes from a gentleman in London, and the question is, what can be done to raise awareness in London? I see that the stem cell treatment in America is different to the one in London. Is there a way to share knowledge? These could, oh, it says this could wait until the end. Is there a way to share knowledge? So I guess
I think sharing knowledge is really important, and why don't we follow up with a person in London, because certainly the academic and the medical community share. I think it's a great idea. You know, I work in the U.S. and then I work with sub-Saharan Africa, but we haven't worked a lot with peer developed countries, you know, like the UK or France or other countries, or the Mediterranean countries. So I think that's really a great idea to do that. So let's follow up on some ideas on how we can get that done.
Great, Admiral Giroir. I actually see a number of questions coming in. So what I'll say is that if individuals have questions, we will work to get them answered.
Yeah.
And we will respond back in a written format to the participants of this session with those answers. So thanks, Admiral Giroir, for your time.
My pleasure.
Thank you. I'm going to introduce the next speaker now. So I now would like to introduce Dr. Wayne A. Frederick, who's the 17th president of Howard University and has been in the role since 2014. Dr. Frederick is a Howard University alum, having specialized in dual medical and a Bachelor of Science programs, allowing him to obtain his medical degree by the age of 22. He is a distinguished scholar and surgeon, having served in a variety of academic capacities at Howard University and the University of Connecticut. He continues to give lectures to second-year medical students at Howard, and Dr. Frederick's research seeks to narrow the disparity in all cancer care outcomes, with a focus on gastrointestinal cancers. Dr. Frederick also suffers with sickle cell disease and has been proud of the efforts of Howard University's Sickle Cell Center, which has been leading institution of research and support for those who suffer from sickle cell disease. Dr. Frederick, welcome.
Hi, thanks for having me. Appreciate it very much. Uh, I am, as you heard, a surgical oncologist, but I came to Howard University and enrolled here at the age of 16 because of Howard Sickle Cell Center, which actually was started in 1972, the year after my birth. In 1971, the National Sickle Cell Act was passed that established opportunities for research and the establishment of centers like Howard University's Sickle Cell Center. Howard University Sickle Cell Center was instrumental in my well-being because it was the first place that I really met anyone else with sickle cell. So peer counseling was added to my overall care package. The other thing that I think was critical about Howard Sickle Cell Center was the opportunity for me to learn about my disease, what my triggers were, what types of controls were necessary, etc. The issue of pain management was one that I came into contact with. I had never received narcotics growing up in Trinidad as part of my disease, my pain management. And it was only until I came to the US and had my first episode of sickle cell crisis that took me to Howard University's emergency room that I received an opioid. I received Demerol, had hallucinations. And I mentioned that because I think the perspective of pain management and what we see in emergency rooms and some of the prejudice that occurs when we do attend to those, when we do show up in sickle cell crisis is one major stigma of the disease that has to be, we have to continue to overcome. I decided to do a general surgical residency despite the fact that I have sickle cell. I have not met anyone else who is a practicing surgeon with who's homozygous for sickle cell as I am. And so again, having the full support of the center, being able to do it at Howard where there were experts in sickle cell was very helpful. My interview process during that period of time did include me being very open about the fact that I had sickle cell. And that was met with resistance in the medical community for people who felt I would not be capable of doing general surgery residency, which I would admit was rigorous. The hours of management that we have now today in our residency training programs did not exist at that time. And unfortunately, as you can imagine, I would get sick as a result of exhaustion and those types of things, stress, but had a very supportive program that saw me through. I mention those things because I do think that adults living with sickle cell do represent a unique aspect of the population and the disease, and having employers be willing to provide opportunities for adults like myself with sickle cell to thrive is key for the success of those individuals participating in careers of their choices. I think that's absolutely critical, and one of the things we do here at the Howard Sickle Cell Center. The only clinical trial I've ever enrolled in my life I did through the Sickle Cell Center. It was a study that was being done through the NIH, looking at adults with sickle cell, looking at the impacts of high systolic blood pressures and potentially trying to lower those to avoid end organ disease, which resulted in me getting an echo every year as part of that program. And as a as a cancer surgeon who has enrolled many patients in clinical trials, having disease experts as well as a support network to encourage me to enroll in a clinical trial was important. And we know that that's the case. The number of people who participate in clinical trials who are African American are very, very small. And that is something that we have to overcome in order to ensure that we can make advances. Howard University Sickle Cell Center has participated in almost every clinical trial of every major drug that has been used to treat sickle cell. We also have significant research projects with countries like Congo, where the incidence of the sickle cell gene is extremely high. And I am certainly encouraged on a personal note when I look at the treatments that are emerging, including gene therapy, stem cell transplantation. I think there is some very, very great opportunities on the horizon. I have a 16-year-old son and a 14-year-old daughter. that my wife and we speak to them often about my sickle cell and also what lays ahead for them. I think there's a lot of promise. And one of the other areas of emphasis that we try to really push at our sickle cell center is the issue of caregivers and recognizing the role that caregivers play. My mom was a nurse for 51 years and would often change her schedule when I was hospitalized. And that certainly, I think, was also a key factor in terms of my overall healthcare. Not everyone is going to be in that circumstance, but I do recognize that caregivers tend to be overlooked in terms of their ability to change their work hours and to provide care for sufferers of sickle cell like myself. And I would love to see more work done on supporting caregivers because of the ecosystem that they create to allow us to succeed. I don't think my story is an exceptional one, and it's not one that I tell often, more because I am embarrassed, more because of the support that I've received here at Howard and in my own personal family circumstance. So I see what has occurred in my life really as a triumph of having coordinated care and a sickle cell center that I could rely on. I was away from here as I did my surgical oncology fellowship and started my career, and obviously in a very different circumstance from the one that I find myself back in here at Howard and as Howard's president. So I'm happy to support the efforts of NIH, and I appreciate you putting on this today and anything that I could do to help going forward, especially in mentoring young people who have major aspirational goals around their education. I'm more than happy to do so.
Thank you, Dr. Frederick. I appreciate you sharing your story and welcoming the opportunity for mentorship. Certainly, as we looked at engagement with patients as they transition from pediatric to adult care, some of the insights that we see certainly is that, there are gaps in opportunities with respect to being able to manage treatment and pursue their personal interests as far as their career and their personal life. So we hope to follow up with you around that. With that, thank you. We look forward to continued engagement by you. And now I will be introducing the next speaker. So Dr. Ankit Sutaria is a newborn screening epidemiologist working with the Georgia Department of Public Health, overseeing newborn screening programs, Children's First Program, and child health surveillance systems. Previously, Dr. Sutaria practiced medicine as a primary care physician at both rural and urban healthcare centers in western part of India. He received a doctorate degree in medicine from Sardar Patel University and received a master's in public health degree from Drexel University. Welcome, Dr. Sutaria.
Thank you, Mia, for the introduction. I will discuss what we have done in terms of sickle cell disease surveillance in Georgia. Next slide, please. So the Georgia Department of Public Health partnered with Georgia Health Policy Center to participate in Center for Disease Control and Prevention Surveillance on Sickle Cell Disease since 2010. The DPH has actively contributed data to the RUS project, which stands for Registry and Surveillance System for Hemoglobinopathies, the PRESS project, which stands for Public Health Research, Epidemiology, Surveillance for Hemoglobinopathies, and the Sickle Cell Data Collection projects. So we, as a Department of Public Health, has shared a newborn screening data, vital records data, hospital register data to this surveillance effort, as well as this sickle cell disease surveillance received data from the clinical partners, as well as administrative claim data, such as Medicaid and state health benefit plan. This results into statewide population-based individual level deduplication of surveillance data from 2004. And Georgia has identified more than 10,000 people living with sickle cell disease in state of Georgia from 2012 to 2016. Can I have a next slide, please? So in Georgia, like Georgia Department of Public Health ensures every child born in Georgia receive a newborn screening. Currently, we are screening for 35 heritable disorder that includes sickle cell disease. We contracted with 3 clinical teams to follow up the positive screens. So once the baby has positive screen, these 3 follow up teams will do the diagnostic and diagnose the baby if the baby has a sickle cell trait or sickle cell disease. So Children's Healthcare of Atlanta does the follow up in metropolitan Atlanta counties. Augusta University does the follow-up for the rest of all of the counties all over the Georgia, and the Sickle Cell Foundation of Georgia follows of positive screen results in for the carrier, and all of the confirmed cases reported to Department of Public Health via state electronic notifiable disease surveillance system. Each year we identify approximately 155 babies diagnosed with sickle cell disease in Georgia, and the trend does not change overall since 2004. Can I have the next slide, please? Through this surveillance effort, we identify some of the challenges. One of the challenge is sickle cell disease is not a notifiable condition in Georgia, and we do not have universal surveillance case definitions to develop a nationwide surveillance system. And we also identify there is a need to develop a long-term follow-up program, especially transition from pediatric to adult healthcare based on the data that we collected through the sickle cell surveillance. And we are in future, we will look forward to build an active surveillance and registry. That's our goal that will help this vulnerable population, and this is a public health need, and we'll try to help these people as much as we can. So thank you for your time, and looking forward for a great discussion.
Thank you, Dr. Sataria. We're doing so wonderful on time. I'm so impressed. So at this time, I just want to emphasize the importance of the discussion around data, and a nuance around newborn screening that I've learned in my work with sickle cell disease is that, while we're able to conduct newborn screening at the state level, there is certainly a lot that is unknown around the total number of patients in the United States, as well as our ability to follow these patients from a longitudinal perspective to understand their care needs. And so we're very excited to have further discussions tomorrow around the opportunities that data can present in addressing some of the challenges with sickle cell. With that, I want to first thank all of our speakers for today. And we're now going to open up the floor for Q&A. There are a number of questions that have come in. So I'm going to try to grab a couple, and we will open them up to any of the panelists to address. Okay. Bear with me. Oh, we've got someone who wants to mentor. That's great. Here's an interesting question. Dr. Frederick mentions that African Americans participate less in clinical trials. Why is that? Do we have any answers there? Do we have Dr. Frederick or Admiral Jar still on the line, or is this something, Dr. Sataria, you can answer?
Well, I do not have data on the clinical trials, but It's very well known in Georgia, like, over 95% of babies who diagnosed with sickle cell disease is African American. But like, I think I cannot answer this question directly.
Yeah.
I could add a little bit to that, Maya.
Yeah.
We've been working in some of our work with a group called the National Patient Advocate Foundation, which has been an advisor to us on the work that we've done with HHS. And they've been working on similar kinds of issues with the fact that that the benefits of genomic screening often are not felt by the African American community because in their findings, talking to community leaders, talking to patients and others, there is an unfortunate history of distrust around the medical establishment, given some of the ways that medical research has not really done well by the African American community historically. So that's something that we're very interested in exploring as part of the roundtable tomorrow and in work going forward. And I think it just kind of emphasizes our overall approach that we're taking more and more in looking at health data, that the impact of social factors, of cultural factors, of trust factors in medicine is so important and something that really needs a dialogue between communities, between patients and physicians and researchers as well.
Thanks, Joel. We do have a question about screening in Georgia. What percentage of newborns don't get screened in Georgia? And this is kind of two-part. What was the statistics about newborns with sickle cell disease yearly in Georgia? Those are kind of two questions.
So in Georgia, each and every baby born in like Georgia receive at least one screen, unless like they like move to out of state or then like our like follow-up partner is not able to locate them. That's the another scenario. But we don't see that much like very few number with the lost to follow-up, and every year like we are diagnosing 155 approximately 155 cases with sickle cell disease through the newborn screening.
Great, thank you. All right, I got so many questions falling in. We have a couple of maintenance questions. There, patient advocates want to be a part of any collaborations. Is this something being considered for future initiatives to capture real-world evidence in the sickle cell patient caregiver community? I'd like to answer that question. And I know that the work that we're doing to address challenges with sickle cell go beyond what we're doing here out of HHS. But through the engagement with the Office of the CTO, we're applying a human-centered design approach. Our intent in this engagement is to directly engage with patients and patient advocates and advocates in the community, as well as clinical care providers. And with that, I'd welcome continued engagement with community advocates in this work. We just got started. We will be rolling out some human-centered design blueprints and journey maps over the next course of about a month or so. Equally, the insights from this report will come out. We intend to have subsequent engagements where we'll have discussions with the community and welcome participation. So we will, if you provide your contact information, we will make sure to include you in future discussions, and you can provide that in the chat box. Additionally, we have a question around why did I not receive an invitation to the roundtable? Joel, do you want to take that one, or?
Sure. No, that's fine. Yeah, we are able in our roundtables, unfortunately, only to include a limited number of people in those discussions. What we try to do, working with HHS, working with our advisors and others, is to have, I guess I would say, a kind of highly representative sample. So the roundtable tomorrow is going to include a lot of people who are patients, a lot of people who are physicians, others who are researchers, others who, address this issue in different ways. But one of the things we've been particularly interested in here, and that has been a really high priority for HHS, we know as well, has been to find ways to really broaden the discussion. So the data for scd.crowdicity.com site that HHS has set up with Crowdicity really is meant to be a way that everybody can participate. And Maya, you might want to add to that as well. But I think it really is a tremendous, tremendous opportunity for everybody on this webinar and others as well to share your thoughts, share your insights. Please participate in the discussion. And it's a way that we can not only have the somewhat focused discussion we'll have with a smaller group at the roundtable, but that we can really expand this to everyone with opportunities for dialogue and follow-up.
Great. Joel, thank you. I think what I'm going to do right now, we are approaching the hour. So one, I would just like to share that it's a pleasure and an honor to have the opportunity to conduct this roundtable on something so personal. I am joined today by my family, who is also able to participate in this. And considering the times, I am at least thankful that we're able to have these events virtually and that we can welcome others to share in some of these discussions that are oftentimes restrictive based off of where we're holding them. So I want to personally thank everyone that was able to join today. I want to thank the code team and partners, Pistis, Alex Wilson on my team, for the incredible amount of effort that has gone into coordinating this event. I want to thank the participants that will join us tomorrow for future discussions. And I want to thank all of you on the line for listening, for engaging, I hope for sharing this discussion as we continue to move forward in advancing new solutions for sickle cell disease. And so with that, I'd like to wrap up. For those of you who will be participating in the discussion tomorrow, we ask for you to hold on for a little bit. We will reconvene at about 1:05 to just give some logistics around the event for tomorrow. So thank you. I encourage everyone to engage with us on the Crowdicity website. We will get that out. That will help to inform the healthathon we plan on having in September. And thank you to Admiral Giroir and Howard University, Dr. Frederick, for your participation today, and Dr. Sutaria. So thank you, everyone.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.